Hello everyone, this is Atchayadharshini and I am currently doing my fellowship in Pediatric Optometry. I am here to demonstrate about certain vision therapy procedures. So among them, first I am going to tell about pencil push-up therapy. So what is pencil push-up therapy? Why pencil? In which cases pencil push-up therapy is used? As we all know, it is used for convergence insufficiency. So what is convergence insufficiency? It is an inability to obtain or maintain their binocular convergence for a length of time without any undue effort. So there are certain symptoms for convergence insufficiency, and it includes occasional diplopia is possible, asthenopia is a main symptom, headache, occasionally blurred vision is also possible. And in some patients, they will hold on to work very close than expected at near. So it comes under pseudo type of convergence insufficiency. Pencil push-up therapy is categorized for near convergence exercises. So in pencil push-up therapy, what is a procedure for doing pencil push-up therapy? So what is a procedure is that pencil is used in any pencil, or shape of pencil could also be used in this procedure. So in the pencil we can stick on alphabets or symbols to allow them to focus on that for their accommodative system. So while doing this procedure, the patient's arm should be outstretched. They should hold the pencil straight to their face, and they should bring the pencil closer. They should look at the alphabet. Why we are sticking alphabets, symbols, numbers in the pencil is that to allow them to focus their accommodative system to one particular part while moving the pencil forward and backwards. While moving the pencil closer and farther, they should focus at one part in the pencil. So that is a main goal for the patient. So the patient's arm should be outstretched. They should slowly move the pencil closer to their nose, and they should move farther. Okay, so this is a procedure. Here the patient should take into consideration that the pencil should be clear, which means it should not go blur, and the pencil should be single, which means it should not be double. While they are moving forward, the pencil will be doubled. So that point they should stop and they should move farther away. So this is their main goal and procedure. So while doing this procedure, the patient should be engaged in the protocol. They should be aware of the protocol and procedure. If the patient is not aware of that, this procedure is takes quite a little length of time for results. So this is a pencil push-up therapy. Now I'm going to discuss about patching. So what is patching and why patching is used? So amblyopia, definitely amblyopia. In amblyopia patients, occlusion therapy, which is also known as patching, is used. So amblyopia is also known as lazy eye, occurs when the brain ignores image signal from a weaker eye. So this will result in amblyopia. This can lead to the amblyopia's eye further loss of function also. So wearing an eye patch on a stronger eye will reduce stimuli, which will force your brain to accept the weaker eye's visual cues. So what is patching? What are the procedures in patching? We are going to discuss about that. So in amblyopia, full-time occlusion is also there. Full-time occlusion of a good eye is also there, whereas it is defined as occlusion during all waking hours. So this treatment is usually performed using commercial adhesive patches. So that is spectacle mounted occluders or special opaque contact lens can also be used. Okay, and used as an alternative to full-time patching. So if there is a skin irritation or inadequate adhesion, so switching to a different brand of patch or preparing the skin with tinctures or any ointments before application can eliminate most skin related problems. So this procedure can also be done. So Rarely, strabismus may result during full-time patching. So it is not known whether strabismus would have occurred with other form of amblyopia treatment or not, but some studies have shown that strabismus may result during full-time patching. Therefore, the child whose eyes are consistently or intermediately straight may benefit by being given some opportunities to see binocularly. So, the modest reduction in patching are employed by many ophthalmologists, like removing the patch for an hour or two a day, like to reduce the likelihood of occlusion amblyopia or inducing strabismus. So there is this technique called partil 1E occlusion. So it is defined as occlusion for 2 to 6 hours per day. This has been shown as same effect and same result as per full patching, as per full time occlusion. Okay, so this partil 1E occlusion is benefited most. So the relative duration of patch on and patch off intervals should reflect the degree of amblyopia. For moderate to severe deficit, at least 6 hours per day is preferred. So patching 6 hours per day is really benefit. So compliance with occlusion therapy for amblyopia declines with increasing age. So in younger age itself, if we done patching, it will benefit the patient. So patching is closing, once again I'm telling, patching is closing patching a good eye, which is a well functioning eye, so that we are forcing the weaker eye to see or visualize the objects. So this is patching method, patching techniques. In patching, there is penalization patching is also available. That is atropine penalization is an excellent treatment option for those patients who are unable or unwilling to patch. The next is prisms or lens fixation. So in prism or lens fixation, prism can be really a powerful treatment for patients who are suffering from asthenopia and diplopia. So in prism prescription, the most important aspect is choosing the patient who will benefit from it. So the first hurdle is ensuring a patient is comfortable in wearing the spectacles. So although a small amount of vertical prism can be prescribed in contact lens, usually prisms will be comfortable in spectacle lens. So although this seems like a very basic requirement for prism use, it can be present it can present an obstacle if it does not done appropriately. So patients who wear contact lenses or already done refractive error surgery, cataract surgery or strabismus surgery may not be happy with the idea of moving back to the spectacle wear, even if it relieves asthenopia or diplopia. So they should be convinced. So educating the patients and on benefiting the prism is an important key for prescribing a successful prism. So patients with, in some cases, like patients with non-strabismic binocular vision disorders such as divergence insufficiency, basic esophoria, vertical heterophoria, can often benefit from treatment with prism, particularly relieving prism, while others convergence insufficiency, convergence excess, divergence excess, basic exophoria are better managed with other treatment modalities such as vision therapy or lenses. So knowing the cause is very important, and simply prescribing the prism will not benefit the patient. So in prism therapy, the prism correction may be successful in patients that have anomalies of Virgin system. There are two methods in calculating the amount of prism. So what are the two methods is that Schert's criterion and Percival's criterion. So there are two methods. So in Schert's criterion, the calculated prism correction needed can be expressed by the formula of calculating prism, that is 2/3 foria minus 1 by 3 compensating fusional vergence blur findings. So the formula used to calculate prism needed based on the Percival's criterion is T is equal to 1 by 3 minus 2 by 3. 1 by 3, that is greater blur value, either base in or base out, minus 2 by 3 lesser blur value, either base in or base out. So base out prism can be used to successfully treat patients with basic esophoria. Base out prism at near can be used in patients with convergence excess that cannot be fully corrected with near additions and vision therapy. So in patients with divergent insufficiency, the use of base out prism is the initial treatment. So base in prism is used to treat patient with basic esophoria, convergence insufficiency and divergence excess. Although relieving prism is not the first line treatment for convergence insufficiency, one study found that base in relieving prism significantly reduced asthenopia associated with convergence insufficiency in presbyopic patient wearing progressive additional lenses. So this is a prism therapy. So the next is computer software vision therapy. So one of the important change in vision therapy equipments in recent years have been introduced is mainly the introduction of computers. So computers are ideally suited for creating the stimuli and variety of variable necessary for vision therapy techniques. So this particularly true for eye movement therapy, eye movement training. So there are several excellent programs for this purpose. The primary system available are products from computer orthoptics, computer aided vision therapy are also available. So we'll discuss about a few software which benefits from in vision therapy. So the perceptual visual tracking program, it is also known as PVT. This is a home-based software program designed to improve saccadic movement. So 5 computer procedures are included, like matching targets, moving boxes, moving line, hidden targets and saccadic tracking. So these 5 are present in the perceptual visual tracking programs. Next, I'm going to just tell you about neurovision rehabilitator. It is also known as NVR. The neurovision rehabilitator therapy modules uses remotes and sensors which provide real space interactive feedback, thus integrating vision, auditory balance, viscomotor control while the patient is engaged in saccadic and pursuit procedures. So this provides the patient with motivating auditory and tactile feedback so that he or she can interact with the program. So this is a few computer software based vision therapy programs.